Hello, and welcome to Focus on Inflammatory Brain Disorders, the nursing management of acute intracranial problems. In particular, we'll be talking about bacterial meningitis in this presentation. Bacterial meningitis is an acute inflammation of the meningeal tissues. It always involves the arachnoid mater and also cerebrospinal infection. It is a medical emergency. If left untreated, bacterial meningitis has a nearly 100% mortality rate. Meningococcus is found in the nose and throat of approximately 10 to 25% of people. Most of the time, it does not cause any symptoms, but it does mean that it can be spread by droplets in coughs, sneezes, and when kissing. Young children and teenagers are the groups that are most at risk from the disease. Occasionally, the bacteria are able to invade the bloodstream and spread to the central nervous system. This allows the infection to develop, and it must be treated immediately because of the high mortality rate associated with bacterial meningitis cases. Organisms can enter the central nervous system from respiratory tract or from the bloodstream, and they enter through wounds of the skull, like basilar skull fractures, as an example, or fractured sinuses. Oftentimes, bacterial meningitis occurs secondary to an upper respiratory viral infection. This picture shows the different steps included in mucosal colonization. In step 1, we see the invasion of the bloodstream. There is survival and multiplication of the organism. And number 3, it causes high levels of bacteremia that cross the blood-brain barrier. And in number 4, we see an invasion of the meninges and the central nervous system. And in number 5, subsequently, bacteria can induce an increased capillary permeability of the blood-brain barrier. This leads to edema and increased intracranial pressure. Let's see there in number 8. We see that increased intracranial pressure due to the swelling and edema. And we also then see the release of pro-inflammatory compounds, that would be our cytokines, from those white blood cells that are infiltrating the central nervous system. So ultimately, these processes lead to neuronal injury. That would be damage to the neurons. There are different organisms that are responsible for bacterial meningitis. Some of those are listed here on this slide. For example, Streptococcus pneumoniae and Neisseria meningitidis. There used to be more bacterial meningitis as a result of Haemophilus influenza, but that's no longer true because of the vaccines, the H influenza vaccines that we have to prevent patients from, or prevent people in general from developing bacterial meningitis from Haemophilus influenza. So we do have vaccines to help prevent that type of meningitis. We do not have, although we do have some vaccines against N. meningitidis, Neisseria meningitidis, there are so many different strains of Neisseria that we are not able to combat that extensively. There is an inflammatory response as a result of this invasion, and it causes an increase in cerebral spinal fluid. And that also, as you know from the Monroe-Kelly hypothesis, that will lead to an increase in intracranial pressure. Here we are talking about Neisseria meningitidis in particular. A meningococcal meningitis is what it's called. We see a characteristic skin rash when the patient has meningococcal septicemia caused by Neisseria meningitidis. Okay. This type of meningitis is characterized by extremely rapid onset of symptoms, and this includes a high fever, skin rash, and severe headache. So an apparently symptomless individual can progress to a serious state within 24 hours. Okay. So one of our goals in healthcare would be to find or come up with an effective universal vaccine against all forms of Neisseria meningitidis. That would be an important goal. The difficulty, as we said earlier, is that there are so many different strains of Neisseria meningitidis that cause meningitis, and so the development of a vaccine against all of them has not been possible. In bacterial meningitis, we have purulent secretions spread to other areas of the brain through the CSF. The CSF is what we see in the picture in blue. Okay, that's where we find all of the CSF in a normal central nervous system. However, that is how it spreads to other areas of the brain through the CSF. If this process extends into the parenchyma of the brain, the actual brain matter, or if there is a concurrent encephalitis, inflammation of the brain itself, then the edema and swelling and increasing intracranial pressure can become extremely problematic. Once again, meningitis is an inflammation of the membranes or meninges and the cerebral spinal fluid surrounding the brain and spinal cord, usually due to the spread of the infection. The swelling associated with meningitis often triggers the hallmark symptoms of this condition. I have highlighted in red the hallmark conditions, including fever, headache, and a stiff neck, which is referred to as nuchal rigidity. As well, there can be nausea and vomiting. So common symptoms of meningitis are fever, headache, and bouts of vomiting, in addition to the stiff neck or nuchal rigidity. Additionally, there may be a distinctive rash if indeed it is caused by Neisseria meningitidis. So again, remember we talked about the reflexes, and we can have Koenig's sign as well as Brudzinski's sign. Both of them, when positive, indicate that there's irritation to the meninges. And the other picture on this slide tells some of the other type of symptoms that can be present when a person develops meningitis. And so on that list, you can also see the photophobia and phonophobia, meaning that their patient is sensitive to light and sound. Okay. Certainly, as the intracranial pressures increase, then we will see changes in level of consciousness or altered mental status in these patients. But the symptoms in red are the ones that patients present with. This is what makes us start to think, does our patient have meningitis? So if meningococcal disease is the cause of meningitis, we see that characteristic rash. And there's just a little bit of more information about that, the rash is described as a non-blanching rash. That is a classic sign of meningococcal disease. And it is rarely present in other diseases caused by other pathogens. So it's fairly unique to this type of bacterial meningitis. And so if this would happen, the individual should definitely get medical advice immediately. Okay. So a little bit more detail on the signs and symptoms of bacterial meningitis. They will demonstrate a positive Brudzinski sign. Remember, that's when the examiner lifts the head, and then we have the automatic flexion of the hips and knees. Okay. Also, they could have photophobia, a dislike of or sensitivity to bright lights. They may develop a decrease in level of consciousness as their intracranial pressure increases. If the level of consciousness declines to the point of a coma, then the patient has a very poor prognosis, meaning that their chances of living through this disease is very low. And now, fortunately, most cases of bacterial meningitis do not result in a coma. But if they do, then the prognosis is poor. Now, we already said that severe headache and vomiting are initial presentation symptoms for these patients. I want you to know that seizures is not an initial presentation for meningitis. That is not how they present. Okay. However, when the intracranial pressures start to increase, we can see the appearance of seizures in these patients. Okay. So that's sort of like, imagine that the brain tissue itself is irritated, and you're going to then perhaps, only like a third of the cases, may develop seizures. Okay. And again, when the headache gets worse as well, and because the vomiting center, or as we refer to it as the emesis center of our body, is located in the brain. So again, when we have this increasing intracranial pressures and irritability, that can lead to stimulation of our emesis center, leading to vomiting. Okay, so we're going to now talk about complications of bacterial meningitis. This is not how they present. These are complications. So an acute complication of bacterial meningitis is increasing intracranial pressures. And this is what causes their unconsciousness. Okay, that's increasing intracranial pressure is a major cause of decreases in level of consciousness, even to the point of being unconscious. Another complication is residual dysfunction of the cranial nerves. In particular, we see cranial nerves number 3, 4, 6, 7, and 8 can become dysfunctional. Cranial nerve number 8, remember, is the acoustic nerve responsible for hearing. So if there is a dysfunction to cranial nerve number 8, hearing can be lost. And hearing loss may be permanent as a result of having had meningitis. A very, very real outcome for patients who have had meningitis as a complication. If there is dysfunction of the optic nerve, then we can see problems with vision. Also, we can have compression of the cranial nerves responsible for ocular movement. Okay, so when there is either a compression of a cranial nerve or an irritation to cranial nerves, we can see changes in vision as well as changes in ability to move the eyeball. So remember, again, cranial nerves 3, 4, and 6 all work together to move the eyeball within the socket. As a complication of meningitis, we can also see irritation to cranial nerve number 5 as well as cranial nerve number 7. Remember that 5 is involved in the sensory portion of the corneal reflex test. Okay, and then irritation of cranial nerve number 7 results in facial paresis, weakness of the facial muscles. We already discussed that we can have loss of hearing as a result of dysfunction to cranial nerve number 8, but in addition to that, we can also have tinnitus. Tinnitus is the ringing in the ears. And because cranial nerve number 8 has a vestibular portion as well as an auditory portion, we do also can have vertigo as a complication from having had meningitis and irritation to cranial nerve number 8. Also, you see here, we can have hemiparesis, dysphagia, and hemianopia may occur, and they may also resolve over time. Other complications can arise due to acute cerebral edema. That is going to result in seizures. Also, we can have cranial nerve 3 palsies, weakness. We can have bradycardia, hypertensive coma, and death as a result of cerebral edema. Other serious complications can occur as well, including hydrocephalus. Okay, there is non-communicating hydrocephalus occurs if the cerebral spinal fluid cannot flow, if it's obstructed. So you see on the left side of the picture, the blue in the diagram is your cerebral spinal fluid in the ventricles of the brain. And when the cerebral spinal fluid increases in amount and swelling occurs, then that can obstruct the outflow of the CSF. So it gets trapped there and we have hydrocephalus as a result. That's a very serious complication as well. But with the most severe form of meningococcal septicemia, we can also see basically a septic shock that develops. Okay. So that, remember, that patient starts out with the terrible rash, and then the patient will develop petechiae and purpura and become very dusky gray in color. they become very hypotensive, low blood pressures, and it rapidly leads to septic shock. And that's what we see on the right-hand side of our screen. The cyanosis of the extremities is very impressive, and the patient is comatose. Okay, so that particular type of disease caused by Neisseria meningitidis is referred to as Waterhouse-Friderichsen's syndrome. Okay, it's not that I need you to memorize the name of that acute complication, but understand that bacterial meningitis, especially the most severe form, it can lead to septicemia and septic shock. Diagnostic studies for bacterial meningitis include blood cultures. Okay, we can grow out the organism with the use of our blood cultures. Just to review, blood cultures must be collected in a very aseptic manner so that we don't contaminate the sets of bottles that are to be inoculated. All right, so there's always 2 sets done with a period of 15 to 20 minutes in between collections. We do both an aerobic and anaerobic bottle in each set, okay, because we want to try to identify that organism. The bacteria may also be found in the CSF, so a lumbar puncture is useful, and then the CSF specimen can be sent to the lab for analysis. Part of that analysis will include a gram stain so that we can detect very rapidly whether we have a gram-negative or gram-positive septicemia, okay, and infection of the CSF. All those other tests as well, all those scans, MRI, CT, and X-rays as well, should be scrutinized for evidence of skull fracture, sinusitis, brain abscess, or sinusitis. Okay, so anything like that that they'll be looking for to see if there has been some way in which they were able to get through all those protective bony structures, etc. Also, we can do other tests that are not listed here, but certainly we would want to do a CBC so we can see if the white blood cell count is elevated. We may also look at the differential to see if there is an increase in the number of infection-fighting white blood cells, such as our granulocytes, our segmented neutrophils. We can see an elevation in that when there is a bacterial infection. Acute bacterial meningitis is a fulminant, often fatal pyogenic infection beginning in the meninges. We already said that the symptoms include headache, fever, and stiff neck. We know that without rapid treatment, obtundation, the patient becomes obtunded, and coma will follow. Diagnosis is by CSF tests, and the treatment requires antibiotics. Okay, often beginning empirically. We're not going to wait till we have a definitive ID on that pathogen. We're going to begin empirically with a 3rd or 4th generation cephalosporin or vancomycin or perhaps ampicillin. Okay. As well, corticosteroids are usually given. And when we consider antibiotic therapy, we need to make sure that the selected antibiotic can cross the blood-brain barrier. Okay. And what we are trying to emphasize here is that the importance of always collecting your specimens for culture prior to giving any antibiotics. Okay. We can, you won't do this as a nurse, but as a nurse practitioner, you may very well examine the fundus of the eye before doing a lumbar puncture, because we can see increases in intracranial pressure by examining the fundus of the eye. And I'm very well aware that in our text and literature, we often see do not perform a lumbar puncture on a patient who has increased intracranial pressure. Okay, that is the rule. Okay, and the reason why is because a lumbar puncture can add to that and increase the already high intracranial pressure. So that is true. However, also, we need to be aware of the fact that we can do a lumbar puncture therapeutically to remove cerebral spinal fluid, thereby lowering a patient's intracranial pressures. But luckily, as I say, it's not up to the nurse to make that decision. It is up to the physician or who's ever performing the lumbar puncture. They understand there is a risk of increasing intracranial pressures further, leading to brain herniation. However, it can also be done to therapeutically to remove cerebral spinal fluid to lower the patient's intracranial pressure. Okay, so there's both sides of that issue that should be considered. Nursing assessment for a patient with bacterial meningitis includes assessing their level of consciousness. Remember, as intracranial pressures rise, perfusion to the brain decreases. And so then we have changes in level of consciousness. Vital signs as well will need to be monitored. And we'll look at this in terms of, well, we can do it right now. Let's look at this monitor. We'll start at the top with our heart rate, 78. Of course, that's perfectly good. And we can even glance at the two leads, and we see that the EKG rhythm is a normal sinus rhythm. We also have a blood pressure up here, and it's a continuous reading, so we have an arterial blood pressure. It's 129/58. And in parentheses, we also see the MAP, or mean arterial pressure, is 79. Going down the monitor, we see the next value is also a continuous or hemodynamic parameter that we are measuring called the CVP, or the central venous pressure, and in this patient's case it is 9. Does anybody remember what would be the a normal CVP in your patient? Okay, so hopefully you've memorized maybe 2 to 6 if it's millimeters of mercury. I don't know what this one is. It could also be a little higher if it's centimeters of water. It could be 0 to 8. So somewhere in there, but whichever scale you're using, the CVP is still on the high end with a value of 9. So that means that's a reflection of our patient's fluid volume status. They're definitely not dry. They're on the wetter side. We have, that is also a reflection of our preload as well. Okay, then continuing down, we have a continuous reading for the intracranial pressure. It is 19. And what is our normal range for intracranial pressure? You may remember from our earlier talks that it is 5 to 10, or according to your book, 0 to 15. Either way, we see that in this patient we have an increased intracranial pressure. And finally, at the bottom of the monitor, we see the oxygen saturation is 100, and our respiratory rate is 12 breaths per minute. So now you have all of this fantastic data or evidence and findings in your assessment. Now, what does this mean? Let's interpret it. Okay, we have to be able to interpret these vital signs. One thing that would help us is if we would calculate the cerebral perfusion pressure. Hopefully you've read about that already, and we know that our brain needs to be perfused, and a normal cerebral perfusion pressure would be between 60 and 80, or perhaps you've memorized a slightly different range, but the bottom level is close to 60. So how do we calculate the CPP if we want to find out if our brain is being adequately perfused? We do that by taking the mean arterial pressure, the MAP, 79, and subtracting the intracranial pressure, and that in our case is 19. So 79 subtracting 19 would give us 60 as the cerebral perfusion pressure, and that is indeed what we see on the monitor in green right above the MAP. So the monitor has already calculated that for us, but we have to understand what that means in terms of our patient. So is this patient sitting very comfortably perfusing his brain? No, perhaps just barely perfusing his brain by the CPP. Okay, so one way to improve perfusion is to decrease the intracranial pressure. Other nursing assessment certainly involves the patient's motor response because of that neuromuscular connection. We also will monitor fluid and electrolytes and elimination patterns as well. So how could we perhaps directly lower the patient's intracranial pressure? Well, one way we can do that is by removing the CSF through the catheter or the drain that's inserted into the brain. A ventriculostomy is also called an external ventricular drain or ventricular catheter. It is a catheter placed into the ventricles of the brain. Those are the fluid-filled spaces within the brain. And it can be used for several things, including draining cerebral spinal fluid externally. Of course, you wouldn't want to drain all of it, but remember, by draining some volume, that provides more room for the other components that are inside that cranial vault, thereby decreasing intracranial pressures. The ventriculostomy is typically connected by a tubing to a CSF collection device, and that collection device can be raised or lowered at the bedside depending on how much CSF is needed to be drained. If we don't need to drain any CSF, then we raise the device. However, if you want to drain some, then you'll need to lower the device. Okay, so simply by adjusting the height on the IV pole, you can either drain or prevent draining of the CSF and actually directly manage intracranial pressures. That special probe or drain is inserted into the brain using a small burr hole. Okay, this is done by the neurosurgeon who drills a hole through the skull, and that's where they can then attach the little intracranial pressure monitor. So, indications for an external ventricular drain. These are the patients who need it, are those who need to be monitored in terms of their intracranial pressure. because we're going to have a continuous reading as to what that patient's intracranial pressure is. We can also insert one of these drains to treat hydrocephalus because of, as we just said, we can simply evacuate or remove or drain some CSF. And if that's the case with hydrocephalus, we can get rid of that excess CSF. Sometimes they even use it to administer medications. You can administer antibiotic solutions directly to the brain, because remember, the blood-brain barrier really prevents us from using certain antibiotics because they can't get through to the brain. So sometimes we would even administer and have that available to do that, antibiotics directly to the brain where the infection may be. And I think those are the main reasons to have an external ventricular drain inserted. But where they like to get you on nursing questions is always related to the safety aspect of our patient who has a catheter in their brain. Okay, when we insert that catheter through the burr hole, through the meninges and into the central nervous system, our concern is, are we going to give them an infection? Okay, are bacteria going to be able to directly enter into the brain parenchyma? Okay, so their questions are always directed toward the risk of infection. All right, so a lot of that has to do with keeping the entry site very clean, and the cleanliness of any type of appliances there, any screws or any area around it should be kept very clean, because we have to understand that we have a great means for bacteria to get into the central nervous system. Okay. Okay, the ventriculostomy allows also for sampling of CSF, so we don't need to do a lumbar puncture. In this case, if the patient already has an external ventricular drain, we can simply sample from that. Okay, but it is connected to a pressure transducer, so it does give us a continuous reading of intracranial pressure. Typically, that ventriculostomy is placed at the bedside, and the burr hole is drilled at the bedside as well, so that we can introduce that catheter through the brain into the ventricle. But there are problems with the external ventricular drain, and one of those big problems is infection. This is a highly invasive procedure, and it does carry a significant risk of infection. So again, remember that anytime you are touching the drain, especially even if you're just simply trying to obtain a sample of CSF to send to the lab, make sure to abide by aseptic procedure and handling. Okay. We would always check the area for signs of infection, especially at a minimum, I should say, of every 4 hours. And take the patient's temperature. Okay, if they are getting a fever when they didn't have one before, we automatically need to think, did we introduce bacteria through this system? Also, we would like to assess or visualize the CSF itself. Is it becoming cloudy? That would be an indication of infection. And so that, of course, would need to be reported to the neurosurgeon in that case. Okay, so now let's talk about nursing diagnoses that are applicable to a patient who has bacterial meningitis. Certainly there is disturbed sensory pattern, okay? especially in terms of increases in intracranial pressure, because we have changes in level of consciousness as well. They're drowsy, they could be difficult to wake up, and also another nursing diagnosis could be acute pain. Also hyperthermia related to fever, and ineffective therapeutic regimen management. So nursing implementation or interventions for our patients who either have it or perhaps to prevent it. Because really the best thing to do would be to prevent our patients from ever contracting bacterial meningitis, given the high lethality of it. So vaccination is going to be our weapon here to prevent infections. Remember that viral infections can often lead to a bacterial meningitis. So we want to vaccinate as well against any of those respiratory infections, even viral respiratory infections. And then if a patient does develop an upper respiratory infection or any respiratory infection, they need to have it treated. There's no sense in letting it continue for weeks and weeks and weeks. Perhaps it will go away, but also perhaps you're going to develop a secondary infection, such as bacterial meningitis. Also, if a person has been exposed to meningitis, it's very important that they receive prophylactic antibiotics. Okay? It's very important that anybody in the household that has been exposed to the patient, because it's highly contagious, that we want to make sure that they are receiving antibiotics as well, even if they are not showing symptoms. Especially with vaccination records in particular, I want to just say a word about making sure that those vaccinations are recorded. Sometimes that is actually a place where a lot of errors occur in pediatrics, is with giving the appropriate vaccination at the appropriate time and recording it as well. So infants should receive their Haemophilus influenza type B, that's your Hib vaccine, on the appropriate schedule. Also, all adults as well should receive their pneumococcal vaccine, especially patients who are immunocompromised, especially patients who already have comorbidities or multiple chronic diseases, and especially patients who smoke, because they are more susceptible to developing pneumonia, and especially patients who live in long-term care facilities, our nursing home patients, etc. Now, our adolescents, they need to make sure that they receive their meningococcal vaccine. That's the MCV4, which is your Neisseria meningitidis vaccine. They need to make sure they get that, especially before they go off to college and they begin living in the dorms. Okay, because whenever people live in those type of communal situations, whether it's college or the military, they're going to be at increased risk of getting meningococcal meningitis, so they should be immunized appropriately. Now, infected people are contagious, remember that, and so as healthcare providers, we're going to place these patients in private isolation rooms in the hospital. Okay, and we were expected to wear masks and gloves when entering the room to take care of them. These patients will be in isolation, lasting at least 24 hours after the start of intravenous antibiotics. Okay, so I want you to remember that. But when they're no longer considered contagious, then perhaps they will be moved out of the isolation room. Uh, It would be important, though, to make sure that as nurses, you should wash your hands frequently and minimize the transfer of those infected secretions to the mouth or nose or to any other patient, for sure. Okay, but when taking care of this patient, again, you'll want to make them comfortable. If they're in pain, you will administer pain medication. But what I want to highlight here is, because there are nursing questions that address this, is that they are placed in a darkened room. Remember, they have a photosensitivity to light and bright light. So to keep them comfortable, it means placing them in a darkened room, possibly even covering their eyes with a nice cool cloth. And the reason why it's so important as well to keep them in low lighting is because it's going to decrease their risk of developing hallucinations. Okay, so this is a big and an important focus of our care in taking care of these patients with bacterial meningitis. Okay, I've highlighted it, I've bolded it, and I put it in red because I want you to remember that this is a very important aspect of caring for the patients with meningitis, because this low lighting, darkened room will decrease their chances of having hallucinations. Okay, nursing care includes observing and recording seizures if seizures occur. Remember, that is a complication that can arise in perhaps a third of these patients. We want to administer anti-seizure medications. They may be there to prevent seizures from occurring, even if they have not had a seizure yet. They certainly can give them medications to manage any fever associated with the meningitis. And because of that fever, we have to make sure we monitor or assess them for any signs and symptoms of dehydration. That's what comes with fevers in general with our patients. Meningococcal meningitis patients should be placed on droplet precautions. Okay, that means a private room. That means a mask for everyone entering the room. And generally, they will be on isolation precautions, droplet precautions, until they have completed 24 hours of the appropriate antibiotic therapy. It is not necessary that they be in a negative pressure ventilation room. But patients with other types of meningitis, such as pneumococcal or viral meningitis, which we haven't talked about yet, do not require isolation. But most definitely, our bacterial meningitis, our meningococcal meningitis, the one that is very, very serious, they must be in isolation. Okay. So how soon should patients receive antibiotics? Well, if they suspect bacterial meningitis, then antibiotics should be given immediately, prior to imaging studies and prior to lumbar puncture. Okay. In patients with a lower clinical likelihood of bacterial meningitis, they can defer giving the antibiotics and wait for the results of the diagnostic studies. I'm not saying this to confuse you, but you have to understand that there are some subtleties. Again, our general rule for nursing questions is to always culture before giving antibiotics. However, when the provider determines that it is highly likely that this person has bacterial meningitis and could be dead in 24 hours, then they may immediately order antibiotics, okay, before they have studies to prove that that's what the case is, okay, because it does result in a greater likelihood that the patient's going to survive. What empiric antibiotic therapy is appropriate? If you have an adult between the ages of 18 and 50 and we suspect bacterial meningitis, they should receive therapy directed against strep pneumoniae and Neisseria meningitidis, and vancomycin would be a good selection. It should be dosed to achieve a relatively high trough level, between 15 and 20 micrograms per milliliter. So there are many considerations here. Empiric antibiotic therapy is the antibiotic that we're choosing before we know definitively what pathogen is causing the illness, okay? And usually when cultures come back, then we can see if we made the best choice for that individual's infection, okay? But generally they will go ahead and start them if it's an emergency situation in which they realize that this patient has bacterial meningitis. So again, very important to remember aseptic technique in caring for these patients. They get frequent small feedings. They do progressive range of motion exercises, and they're going to increase their activity as tolerated. So let's review nursing care of our patients with bacterial meningitis. Isolate the patient as soon as meningitis is suspected. Maintain isolation precautions per your hospital policy. Droplet precautions are required, which requires a private room or at least a room with cohorts that are wearing a surgical mask when they're within 3 feet of the patient, and appropriate hand hygiene and use of designated equipment. So in other words, we're not going to be sharing our blood pressure cuff or thermometer when we have a patient who has meningitis, okay, too contagious. We want to implement fever reduction measures. Sometimes it even calls for measures such as a cooling blanket. And we are required by law to report meningococcal infections to the public health department. Provide a quiet environment, a dark, quiet environment. This decreases environmental stimuli and their risk of hallucinations. Bed rest. As always, when it comes to neuro, we want the head of the bed elevated at 30 degrees. This is advantageous for draining of the upper head and body. Okay, we don't want our neck to be kinked so that blood cannot return to the right side of the heart. So we want a nice body posture in bed, nice and straight, and the head of the bed at 30 degrees. Seizure precautions are important as well, even if they haven't demonstrated seizures as of yet. We wouldn't want the patient to be injured during a seizure if it should arise. Always replace fluid and electrolytes as indicated by patient's lab values. And then realize that our older patients, older adults, they are at increased risk for secondary complications, such as pneumonia. So some really good goals or priority outcomes for these patients would be that the patient will have minimal disorientation. The patient will lack evidence of agitation, which is a change in level of consciousness. The patient will have satisfactory pain relief. The patient will participate in treatment, and the patient will have a normal body temperature. All of those are great goals.